afternoon to everybody, and once again, welcome on this lovely Sunday afternoon. We are taking the gender sensitive endocrine module further, and a very, very interesting topic with a fantastic faculty today. Today, we are going to discuss whether do men really pause? What are our concepts about andropause? What exactly do we believe? And what do we think is just simply hearsay? And to take the proceedings further, we have none other than Sir Dr. Subhankar Chaudhary, whom we all know as the ex-president of ESI and the professor and head of IPGMER and SSKM Hospital, Kolkata. A warm welcome to you, sir, and over to you for the further proceedings.
Thank you very much, Sheila. It's a wonderful opportunity to be associated with any program of Endocrine Society of India. It's always a proud privilege. And I really admire the way the current leadership of ESI has taken things forward, literally turned a sort of problem into an area of strength. Now we can reach out to so many people from across the world and get them involved in our activities. And this afternoon's program is, of course, very interesting. We may not yet have final answers to some of the questions, but it's always important to raise the questions and then try and get the answers. And so gradual decline of gonadal function is something that is seen in males, whether or how many of them require treatment, of course, will be discussed by our esteemed speaker. But at this point of time, it's my privilege to welcome amidst us Professor Juro Makut. I hope I've got your pronunciation correct. And he is Professor of Internal Medicine and Endocrinology at the University of Belgrade in Serbia. He is also head of the department and deputy director of Clinic of Endocrinology, Diabetes and Metabolic Diseases, Clinical Center of Serbia. He did a number of sort of academic attachments in different university hospitals in Bologna, in Uppsala, and Oxford, and completed his postgraduate program in reproductive medicine from the University of Geneva. And he has had numerous publications. He has authored more than 90 original articles and reviews in peer-reviewed journals, and authored book chapters, and also co-edited a book on PCOS. And he has held numerous important positions. He has been the scientific committee chair of the Serbian National Congress of Endocrinology, and he is associate editor of the journal Hormones and on the editorial board of several other endocrine-related journals, and is, of course, a reviewer for numerous international journals. So with this, we would like once again to welcome Professor Makut amongst us, and maybe with a few more opening comments from your side. We have a very interesting program laid before us. We start with the quiz program, and then we have the talk, and then we can have we'll have discussions, I'm sure. Over to you, sir. Please unmute yourself. Your mic is muted. Yeah, that's right.
Can you hear me now? Hello, everyone. I'm really very glad to see you again and to hear you again. I thank to Sheila and to Subhankar for the very nice introduction, and I'm really very excited about what to hear from your today's webinar. This is really a wonderful series of the webinars that you really very nicely prepared, and I really enjoyed a lot last time. So I believe this time it will be the same.
Thank you. So let's go on to the quiz, and it will be presented by a very dynamic young endocrinologist of our country, who is assistant professor in endocrinology at the All India Institute of Medical Sciences, Raipur, Dr. Amrita Ghosh, for the quiz. And who provides the answers to the quiz? You only provide it at the end?
At the end.
Yeah, good. Please unmute yourself and go ahead.
So, Thank you, sir, for the kind introduction. I thank Endocrine Society of India, Dr. Hari,
Audible. Yeah.
the
Now
opportunity.
it's, yeah, it's okay. Now it's,
I have a set of 10 questions for the audience, which I'll be going one by one. Okay. So, am I audible?
Yes, sir. Go ahead.
yes.
Okay, thank you. The first question, all of the following are true about androgens in men.
Sir, we are not able to see your screen. Would you try to share it once again?
Okay. It's sharing. Just a minute.
Please try now. Perfect. Full screen, please.
Okay. So the first question, all of the following are true about androgens in men, except testosterone is secreted almost exclusively by the testes. Dihydroepiandrosterone and DHEAs are produced almost exclusively from the adrenal glands. Approximately 85% of serum androstenedione levels are contributed equally by the testes and the adrenal glands, whereas the remainder originates from peripheral conversion of testosterone and DHEA. Most dihydrotestosterone is secreted directly from the testes, whereas the remaining 20% is derived from 5-alpha reduction of testosterone in peripheral tissues. The next question, which of the following androgens bind substantially to the androgen receptor? Testosterone and dihydrotestosterone, testosterone and androstenedione, testosterone only, dihydrotestosterone. Next question, which of the following are true about androgens in men, except testosterone levels decline rapidly after the age of 50 years. Total testosterone declines at a more rapid rate than free testosterone. Free testosterone declines at a more rapid rate than total testosterone. Both total and free testosterone declines at a similar rate. So the question will be, which of the following is true? Except is the wrong word. So the question is, which of the following is true? Aging is associated with decreased rate of production and increased rate of metabolic clearance of testosterone. B. Decreased rate of production and decreased rate of metabolic clearance of testosterone. C. Increased rate of production and increased rate of metabolic clearance of testosterone. D. Increased rate of production and decreased rate of metabolic clearance of testosterone. The next question. Aging is associated with all of the following testicular changes, except A. Decreased number of Leydig cells, reduced Leydig cell response to gonadotropins, and decline in sex hormones. Atrophy of seminiferous tubules and lower testicular volume. Decline in volume of seminal fluid and sperm motility. Impaired Sertoli cell function and reduction in inhibin B levels. Next question. LH secretory pattern in the elderly displays decreased pulse amplitude and increased pulse frequency, increased pulse amplitude and decreased pulse frequency, decreased pulse amplitude and decreased pulse frequency, increased pulse amplitude and increased pulse frequency. Next question. Loss of libido represents the most specific symptoms of male. So, among all these, which of the following is the least specific of hypogonadism features? Poor morning erections, loss of libido, erectile dysfunction, decreased muscle mass and strength. So, which is the least specific symptom? Testosterone replacement therapy may be considered in men over 50 years of age if they have A. Clinical manifestations indicative of androgen deficiency, low serum bioavailable or free testosterone levels, both of the above, or either of the above. Contraindications of testosterone replacement therapy include all except metastatic prostate cancer or breast cancer, age more than 65 years, hematocrit more than 50, poorly controlled congestive heart failure. I guess this is the last question. The least likely side effect of testosterone replacement therapy is gynecomastia, increased PSA, reduced HDL cholesterol, increased risk of prostatic carcinoma. The least likely side effect. Okay, so we are done with the questions. I'll hand over the proceedings to Suvankar Chaudhary, sir.
Thank you, Amrita.
Sir.
I hope these had a reasonable number of correct answers. We should see at the end covered a broad area of androgen-related endocrinology. So now we will go into the topic proper, the talk that is to be delivered by another very dynamic endocrinologist of our country, Dr. Deep Datta, who trained with us in Kolkata, and then he has made a name for himself. He has published very prolifically. Even at this age, I think his publications are very large, and is always an excellent person to interact with, very knowledgeable. And so he will talk on the issue of andropause. So over to you, Deep, and quite excited to hear and to learn from you. Always an opportunity. Please unmute. Please unmute yourself.
Yes, sorry. Sir, it's a big honor to be speaking in front of you because I have learned all the nuances of endocrinology from you at IPGMER, and not only that, over the larger aspects of life also. You have been a great role model for not only for me, for many generations of endocrinologists. So, so yes, the topic for today's is do men pause or not? And thanks to Dr. Amritabo, I mean, he has some very valid questions. Hopefully, we will be able to answer some of those questions in the next 20 minutes or so. It's a difficult question. Do men pause? Also, let me share with you some data. We know there is a clear-cut female menopause, but andropause is something which has always perplexed us. So I have no conflict of interest with regard to this presentation. So let me share some data. So now I did some Google search to find out what are the oldest age till men actually fathered children. So the top 10, among the top 10, the first and the three rank comes to India. The oldest gentleman is Mr. Ramjeet. He fathered a child at the age of 96 years. And the third on the list is Mr. Nanuram Jogi from Rajasthan. He fathered his 21st, the officially 21st child at 90 years of age, and he himself claims he's not sure how many kids he fathered. Well, we have all seen Lawrence of Arabia, and we all know Anthony Quinn, and he also, his youngest child was born when he was 81 years of age. So for some men, there's a lot of evidence to say that they really do not pause with regards to the male sexual function. On the other hand, if you look at infertility, male infertility, the proportion of men who are never able to procreate or have their own kids has increased over the time. The US male infertility market in terms of expenditure has also gone up significantly. So there's a dichotomous thing. So some people, I mean, there is nothing called andropause. Some people, I think they never achieve their full fertility potential. So the key here lies is to find out who are these people who are going to have adverse male fertility outcomes, what are their predictors, and how we can help them. I think that would be more important from endocrinologist's point of view. And of course, as a bell-shaped curve of a normal distribution, we will always have some men who will never pause. So from hormone points of view, we call it hypogonadism, which is a state of male hormone deficiency, the key male hormone being testosterone. And the way we measure it, the most robust way to measure testosterone is the total testosterone levels. As in any endocrinopathy, just randomly doing testosterone assays are going to land up in more soup. So we do a test only when there are certain preclinical or pre-test clinical predictors. Only then we can take the report into perspective, or else we'll be creating a lot of labomas or lab diagnosed false diagnosis. So when do we test testosterone? So we need to have some objective clinical evidence of male hormone or testosterone deficiency, which can be clinical symptoms like decreased libido. The patient might complain of erectile dysfunction. A very important sign which we should take from history from the patient is whether they have nocturnal penile tuminescence. Sometimes we do a stamp test to actually document nocturnal penile tuminescence. And then there are certain surrogate measures of androgen deficiency, which are very non-specific. They can be found in other clinical syndromes also. They are like increased central obesity, increased visceral adiposity, loss of lean muscle mass. And yes, men also sometimes will have hot flashes. It is not limited to women. Then certain mood changes like depression, fatigability, and has also been linked to testosterone deficiency. So menopause has perplexed not only the medical fraternity but the general population at large. The key point is only in a patient with objective symptoms we should go for hormonal evaluation. When we talk of male hormone deficiency or age-related decline, I think it is important to also discuss a certain group of males who will never have optimal levels of male hormone. So if they have male hormone deficiency before puberty, their body structure will not, the physique will not represent the appropriately fully developed male. Like they'll have very small testes, like in with congenital hypogonadotropic hypogonadism, or in severe Klinefelter syndrome also, where the testicular volume will be less than 6 ml. In severe cases, in case of intrauterine male hormone deficiency, where the diagnosis is totally different, the etiology is totally different, we may even have undervirilized male. So when we talk of male hormone deficiency, if on clinical examination we are able to document a really normal testicular volume, which is around 16 to 20 ml or more, well-developed pubic hair, a well-developed phallus, we know whatever the problem happened, it started after puberty and not before puberty. So that's a very good information we can get by a simple clinical examination. Similarly, eunuchoid body habitus typically happens when the deficiency of male hormone starts before puberty. Any onset of male hormone deficiency after clear-cut puberty will have normal body proportions. So how do we objectively clinically define? So we have different scores like the androgen deficiency in adult male scores. These are simple questionnaires which are available in different vernaculars. The patient is supposed to fill them on their own. Because there are certain private questions. If we ask them, the patient will feel shy or may not fill the question correctly. So give them the peace of mind in a silent room. They can fill it blindedly without writing their details. Then you will get a more objective clinical phenotype of the individual. So we can use any of the validated scores. So people who fulfill this andropause rating scores or the androgen deficiency in adult male scores, these are the people who need to undergo further hormonal evaluation. I think this is a secular trend, how the hormone level, the male hormone level testosterone changes in all of us. So we know there is a pubertal surge and the peak is attained by around 16 to 22 years of age. And then after 30, there is an age-related normal decline in testosterone. And there comes the variability. Some people it doesn't go down, some people it goes down really fast. And on average, it goes down by around 1% every year. So when we talk of this age-related male hormone decline, or which sometimes become manifest as andropause after maybe 50s, the challenge is the age range is also not well defined, because we know the age of menopause is like anywhere between 40 to 50 years. We know for a girl, the age of her menopause will closely mimic the age of a menopause of the mother. We don't have any such age cutoffs or range to define andropause. That's a clinical challenge till now, but we know, as the picture shows, as the male hormone level goes down, all the phenotypic features of metabolic syndrome, they tend to become more pronounced with age. And hence, since we are not clearly about what are we dealing with, we have different names. Sometimes we call it the partial androgen deficiency in adult male, sometimes we call it the androgen decline in aging male, sometimes we call it andropause, or sometimes we just call it a blind overlapping term, testosterone deficiency syndrome. So we are going to find out, first of all, what are the consequences? Why do we really need to diagnose or treat? Because it affects the individual. It affects the lifespan. It increases mortality. It affects the quality of life. Androgen deficiency has been linked with not only decreased muscle mass, but even increased risk of cardiovascular events, increased risk of metabolic syndrome, dyslipidemia, diabetes, osteoporosis, increased risk of fractures. So they have some really dreadful objective consequences. Hence, we need to diagnose and pick up which are these males who are having significant androgen decline with age. So coming to Dr. Amrita's one of the question, I think the answer is here. The question was, when there's a decline in male hormones, we all know for all hormones, we have the total hormone levels which are bound to proteins, and there's something called the free hormone levels in the circulation, which is the more bioactive form. So for testosterone, also we have the total testosterone, and because which measures the free as the part of the hormone bound to sex hormone binding globulin, which is the primary protein to which the hormone is bound. As we age, not only does our total testosterone level comes down, our SHBG level also goes up with age. So the fraction of free testosterone level sometimes tends to decline faster as compared to the total testosterone level. So we will have many patients with symptoms of androgen deficiency, and the testosterone would be in the so-called normal range. That brings us to the next question. What is the normal range of total testosterone? Again, we have different definitions. The Endocrine Society of USA, as per their definition, it is anywhere between 350 nanograms per deciliter to 1000 nanograms per deciliter. There are certain other guidelines which says anything less than 250 nanograms per deciliter, we call it significant androgen deficiency. There are few societies which have even lowered it to less than 200 nanograms per deciliter. So the take-home message is any testosterone level less than 200 nanograms per deciliter, it is significant clear-cut hypogonadism. Again, as with most hormone assays, a single reading is not good enough. In the setting of appropriate clinical symptomatology, if we get a clear-cut low testosterone, it's a good practice to repeat the testosterone assay after 4 to 6 weeks. Again, when do we do the assay? Because there's a diurnal variation in testosterone levels. So a good clinical practice is to measure the testosterone levels in the early morning, anywhere between 7 to 11 a.m. We are happy because that's the time our testosterone tends to be highest. So we want to prevent false positivity. We don't want to overdiagnose androgen deficiency. If we measure in the evening, like 6 or 7 p.m. in the evening, we would be measuring the trough level of testosterone, so we would be overdiagnosing. So hence it is not recommended. So in people, what about patients who have the level between 200 to 350 nanograms per deciliter? If they are symptomatic, there are some data to suggest that in these patients, you may go for a free testosterone assay. and that might come low, and that would support a diagnosis. But let me tell you, total testosterone is in nanograms per deciliter. Free testosterone is in picograms per ml. So that's a really low value, 10 raised to the power minus 12. Whenever we try to measure hormones at such low values, the assay becomes less reliable, the assays are less robust, and they are more difficult to replicate. So we should be avoiding free testosterone assay unless you really need it. Total testosterone is the best way to measure androgen levels in average male individual. So coming to the consequences, we did publish some data on secondary bone mineral loss and different endocrinopathies, and we did show that when we compared bone mineral density in various endocrinopathies like type 1 diabetes or hypergonadotropic hypogonadism or hypogonadotropic hypogonadism, we found that the burden of bone mineral loss, the prevalence of osteoporosis using Z scores was higher in people with hypogonadotropic hypogonadism as compared to those with andropause. So it's highlighting that if the onset of male hormone deficiency is earlier, more are the dreadful consequences, or more are the end organ damage. Here we are talking of in terms of impaired bone health, which would increase the risk of fractures, symptomatic or asymptomatic vertebral fractures. An important cause of male hormone deficiency, a secondary cause, is HIV infection. That's a pandemic. Thankfully, it is now much better controlled in our country than maybe it was 15 or 20 years back, thanks to a national in the NACO, which has done some great work. So in people with HIV, we did a bone mineral assessment, and we did an assessment of their testosterone levels in male with HIV infection, and we found that those who had a lower CD4 count at the time of diagnosis, a more severe disease at onset, those with a younger age of HIV infection and had lower vitamin D levels, they were greater predictors of male hypogonadism, defined as testosterone less than 300 nanograms per deciliter in this study. Now, the problem of diabetes and the problem of diabesity has contributed to the increased burden of late onset hypogonadism, or what we call andropause, in our society and in the world at large. So it's the dual link. People with diabetes and obesity, they have a higher risk of hypogonadism, and specifically secondary hypogonadism. And on the other hand, if somebody has a primary testicular defect or a hypothalamic defect leading to hypogonadism, they also have an increased risk of diabetes and metabolic syndrome. When we talk of diabetes, when we talk of obesity, obesity leads to increased adipose tissue. There's an increased aromatase activity in the adipose tissue, which leads to peripheral conversion of androgens to estrogens. And that contributes to hypogonadism or low testosterone, both clinical symptoms as well as biochemical evidence. In the large majority of these males, if we are able to control the obesity, if they lose the body fat, their testosterone level actually improves. And this is primarily mediated at the level of hypothalamus and pituitary. So this pattern of obesity or metabolic syndrome induced hypogonadism is primarily a secondary hypogonadism or a central cause of hypogonadism. It is not a primary hypogonadism. And we know with the increased prevalence of diabetes in the country, around 9 to 10% prevalence and around 12 to 15% prevalence of pre-diabetes, we are going to see more and more people with obesity-related so-called reversible secondary hypogonadism. The screening, there is no role for routine screening of testosterone in the general population. It is not recommended. It is not cost effective. We already discussed screening should be done in the appropriate patient with appropriate symptomatology. How do we screen? I think we have already discussed. And if we have documented clear-cut low testosterone, it's a good practice to find out what are we dealing with. Is it a pituitary or a testicular cause? A simple pooled LH FSH assay is going to give us a lot of information. FSH primarily will be raised in the setting of primary hypogonadism or testicular hypogonadism, whereas the pituitary cause, they will be low or inappropriately low for the level of testosterone levels. A very important syndromic cause of primary hypogonadism is Klinefelter syndrome, which can be a clear-cut presentation, which can be mosaic also. Certain Klinefelter syndrome people, they have normal fertility also, so they are never diagnosed. The entire spectrum is there for Klinefelter syndrome. If we have diagnosed a low LH-FSH, if we have diagnosed a secondary hypogonadism, a good clinical practice is to look for other pituitary hormone deficiency, because pituitary is a small gland. Evidence of one axis defect is itself a risk factor for other axis defects. So we are primarily concerned of two hormones which are critical for survival, which is cortisol deficiency and a thyroid hormone deficiency. We need to look at the whole thyroid profile. Just looking at TSH will lead to missing the diagnosis of a secondary hypothyroidism. Also, if we have clinical evidence, we may have to do a structural imaging of the pituitary, and the best way to go about is doing an MRI of the pituitary. These are the entire list of secondary or organic causes of hypogonadism. Drug abuse, opioids abuse, exogenous steroid abuse, gym steroids, bodybuilders, they all cause iatrogenic hypogonadism. And of course, any chronic disorder, chronic systemic illness linked associated systemic inflammation is going to cause a functional hypogonadotropic hypogonadism. So why do we need to treat? We know we need to treat because the untreated hypogonadism, even if late onset, can lead to some end organ damage in terms of metabolic syndrome, fractures, cardiovascular mortality. The treatment again is highly symptomatic. We treat the symptoms. Whatever the symptoms, we treat the person accordingly. So if you're talking of late onset hypogonadism, where the person has completed family, I think the treatment, a primary treatment would be testosterone replacement. But as a part of the whole male hormone deficiency, if it's a young male, infertile male, I think testosterone replacement is not the way forward. I think we may have to start with an HCG replacement, because we want to improve the fertility, we want to improve the semen parameters in those. So the treatment depends on the age of presentation and the needs or the desires of the patient. So when we talk of testosterone replacement, there are multiple ways of going into. We can give the monthly or the bi-monthly intramuscular testicular testosterone injections. Advantage, they are cheap. Advantage, there are no compliance issues. But it's a prick, so many people do not like pricks. There are oral testosterone replacement like testosterone undecanoate. The testosterone patches are also available, but they're more costlier treatments as compared to injectable testosterone, which hence the injectables are quite popular in our setting, in our practice. I think the methyl testosterone or the fluorinated testosterone as preparations should not be used, because they have been linked with increased onset of hepatic adenomas and hepatic failure. So they should not be used in clinical practice. So monitoring, very important. We monitor the testosterone levels. The key is to keep testosterone in the low normal range, like maybe 350 to 500 nanograms per deciliter. We are not going to targeting a very high level of testosterone that will end up causing more side effects. We monitor the hemogram. The hematocrit should never cross 50%, or we need to stop the treatment. Look for symptoms of prostatism. If the American Urological Association AUS score is more than 19, we need to stop the treatment. In these patients, especially in late onset hypogonadism or andropause, we need to monitor the PSA levels. Any PSA level which crosses 4 nanograms per ml, sorry, we have to stop the treatment. If an annual rise in PSA levels is more than 1.4 nanograms per ml per year, again, we need to stop the treatment. And hence periodic evaluation is very important. So adverse effects, yes, any treatment has some adverse effects. We discussed some of them. It can cause oily skin, acne in some, and very important, testosterone replacement can worsen gynecomastia. So that's very important. So in them, we may have to give some aromatase inhibitors like letrozole, or maybe SERM like tamoxifen works great in the setting of gynecomastia. Hence, give testosterone at the lowest possible dose so that the patient's symptoms are taken care of and the patient is not exposed to increased side effects. Any history of breast cancer, there is a theoretical risk of increased breast cancer and also sleep apnea with testosterone replacement therapy. Now, what about CV risk? Now, again, so much of confusion is there, because we know androgen deficiency is the risk factor of cardiovascular events. Also, there are some data to show that if we replace testosterone, that may increase cardiovascular events. So what is the important take-home message? So the important thing is, in patients with low cardiovascular risk or moderate cardiovascular risk, low dose testosterone replacement is safe. But in patients with high cardiovascular risk, we should not be go for going for testosterone replacement, that may further increase the risk of cardiovascular events. So basal cardiac function evaluation is a good practice. As a rule, anybody who has had a myocardial infarction or a stroke in the last 6 months, we should not be going for androgen replacement therapy. Similarly, in symptomatic uncontrolled heart failure, there is no role of androgen replacement therapy. So the very population whom we are targeting treatment are the population who are likely to have increased burden of symptomatic or asymptomatic underlying cardiac disease. Already discussed, there is no role of routine testosterone screening at any age group, be it more than 50 or 65 or even 70 years. We just screen for the hormones only in a symptomatic patient seeking treatment from us. A few words on the anabolic steroid abuse and how is it contributing to the androgen deficiency, not only in late male, elderly male, but also in the middle-aged or young males. Also, it's a big problem. They come with infertility later in life. So selective androgen receptor modulators, these are molecules who are supposed to have beneficial impact on the muscle mass, on body fat distribution, without the so-called adverse impact on the prostatic tissue and or maybe the breast tissue. They are not available in clinical practice. They are not approved, but trust me, you can go search on Amazon, you can search on Flipkart, you can search on the dark web. Lot of androgen receptor modulators are freely available. You go to any gym, at least in Delhi, I can tell you, most of the people there are using androgen receptor modulators for body physique development, taking part in different gym, different competitive bodybuilding competitions. I did a PubMed search on selective androgen receptor modulator. There's a lot of different papers are there, but most of the studies have been done in animal models, cell culture models, very small human studies, negligible human studies are there. The different molecules, some of them are like ostarine are there. So the key thing is we as endocrinologists should strongly discourage the use of these molecules because the safety is not yet known, although unfortunately they are available in the black market. So when we talk of slightly younger onset hypogonadism, when we are talking of spermatogenesis induction or fertility, the treatment approach is totally different. Chronic HCG therapy, initially maybe twice weekly to maybe every alternate days is the way forward. We can later add a HMG depending on the response on the sperm count, how well the sperm count is improved. Again, the basal testicular volume has a major role. Males with a testicular volume of more than 8 ml, they tend to respond better with HCG therapy as compared to those who have a basal testicular volume of less than 8 ml. Their fertility outcomes are not so great. Other treatments for male hypogonadism, I think aromatase inhibitors have a great role. They have a great role in the so-called obesity or metabolic syndrome or diabetes-related hypogonadism. There are studies to show that once weekly letrozole of 0.5 milligrams once a week given, they greatly reverse the low testosterone linked to diabetes. We should tell our patients, see, the primary treatment is that you should go for a better glycemic control, you should lose your body weight. That will greatly improve your testosterone levels and the associated symptoms. But till the patient do that, there are data to suggest that once weekly letrozole will also work great in terms of improving the testosterone levels in patients with metabolic syndrome or diabetes-related secondary hypogonadism. So the take-home message at the end would be that, yes, a lot of men do never pause in their life. They are lucky. But let me tell you, a greater number of men are pausing earlier and earlier. Why? We do not know. The burden of diabetes is contributing to a more and more earlier pausing in a greater number of males. Also, I missed out, there's an important role of endocrine disruptors in the increased prevalence of infertility in males and the earlier pause in a good number of males. Plastics are major endocrine disruptors like bisphenol A. BPA is the largest produced plastics. It is totally banned in USA and Europe. Unfortunately, we India continue to be one of the largest producers of BPA. Plasticizers are solvents which are used to molding plastics. They are also major endocrine disruptors. Most of these plastics, the heavy metals, the cadmium, the lead, the arsenic, they have estrogen mimetic properties, and all of them have an adverse impact on direct testicular function and also a release of LH and FSH at the level of pituitary. Thank you so much.
Thank you. Thank you, Dr. Deep, for an excellent talk, starting with when to consider suspect hypogonadism in aging males, how to establish your diagnosis and how to treat, and taking the other considerations, especially the adverse effects related to treatment. So, shall we first have a few comments from Professor Juro, and then we go on to answering of the quiz and then open up for discussion? Yes, Professor Juro Bakut, for your comments.
Yes, Deep, thank you very much to the very nice presentation. This is a very nice overview of everything that is related. And I was really very interested to see how do you manage in your, approach, and what are the therapeutic options. So you very nicely covered everything, even the use of the androgen modulators. So even with a very small doses of clomiphene, even you can increase the level of testosterone. This is amazing. So if someone is really susceptible to the rise of the testosterone, you can do this really and achieve a very good level. I would like just to stress on something that is nowadays really an interesting topic, and this is the endocrine disruptors. So maybe you see a lot of papers that is dealing with the sperm count and the hypoandrogenism. So we have to think about the of the chemicals that are around us. So we do not have a strategy to this, but I think that we should think about the possibilities how to ask, even at least in the questionnaire to the patient. So when we are taking history, maybe in the discussion we can ask, and that should be a good point to your members to ask about the everyday life and the habits. This is also interesting, and I think that we have to include this in our questionnaires. I noticed what was really interesting is that you
Please unmute yourself once more, Professor Bakut.
Yes, I lost the connection. So what I noticed was for instance, the approach toward the doses. This is the recommendation that is something, internationally accepted. But for instance, for the injection type of the testosterone, which is the mostly acceptable with my area, we have some other substances that we can provide even at the 3 to 4 weeks of every 3 to 4 weeks. So this is really depending upon the patient. We have to ask, and maybe I don't know if you consider that we should have the questionnaire to ask the patients on the therapy how do they respond, because this could be really very useful to provide the type of the short questionnaire to see when at which day or at which week you have to overlap with another dose. So these are some very practical things which you really very nicely addressed in your excellent overview. Thank you very much.
Thank you, sir, for those nice comments. Can I ask you about the approach about attitude of aging males in your part of the world? India, I would think, is a mini continent. For example, in the eastern part of India where I am located, maybe people men, I would say, are not so sort of concerned about virility, about their macho nature and all. But maybe where Deep is now located and practicing, possibly it's more of an issue. People would take more pride in their virility. So in Serbia, is there a demand from the aging males to have prescription of androgens?
Well, we have. I think that we are sharing the same attitude of the males. So males are closed and the women are open. So we can very and much more frequently have women complaining about their lives and feelings and whatever. With males, it's really complicated, and we have this what was covered from presentation, the secondary forms. So especially with the obese and especially with those in transition into the type 2 diabetes, they came and tell us that they are weak, that they are fatigued and whatever. So we are also the very conservative, how can I say, society, and people, I mean, males are not coming very often with any problems related to that. So probably we have to change the approach. We must maybe have the clinics separated to the, I mean, steroid deficient states, not only menopause or andropause, but something that is related to the reproduction issues. We have fertility problems, and we have very nicely organized fertility clinics in Europe, but I think that we are lacking the clinics related to those types of problems, because I truly believe that every man who is obese and suffering from, I mean, diabetes or increased glucose has relatively decreased androgens, and this is one of the very, very common things. And I fully agree with you that we are sharing the same approach. So very conservative, and we do not have many males coming to the office. Not
right. So that's a remarkable statement that you've made, that males actually are more closed, women are more open, and it's actually also true that a number of times it's the female partner who actually points out that the male is not performing enough and that something needs to be done. That's absolutely correct. And then the other issue, Deep, you mentioned very well about what to do or showed us an algorithm as to measure testosterone. If it's low, then go for LH-FSH. I must admit that those algorithms look good in consensus statements, they look good in textbooks, but when you have a patient in front of you where you suspect someone has got hypogonadism, male hypogonadism, I would at the first go advise not only testosterone but also the gonadotropins. I would also add prolactin invariably in all of them, rather than having them come back and go back to another test and then come back. I mean, that it's clearly, and at this point of time, of course, it does add a little bit extra cost, but it's generally not prohibitive if you add one extra hormone. I mean, what do you do in your practice?
I agree with you, sir, because people everybody is busy, so we need to save time. And I think what your approach is perfectly. I agree with you, sir. Absolutely.
Right. So there's another thing that we need to remember as to what causes this age-related decline in testosterone. It is possibly both a primary and a secondary form of hypogonadism, both the testis as well as the response of the pituitary hypothalamus system, which is lagging in some form. And the other issue that we also, I think Deep just referred to, was that the robust circadian rhythm of testosterone secretion, that's also blunted as you age. That's another issue that we see. So shall we now go on to the answers to the quiz, and maybe then come back and have a few more discussion points? Yes, Amrita, we are all waiting. We scored 0 out of 10. So let's have the correct answers.
Thank you, sir. We move on to the answers. The first question: all of the following are true about androgens in men except when testosterone is secreted almost exclusively by the testes, and DHEAs are produced almost exclusively by the adrenals. The answer here is that most dihydrotestosterone is about 80% is derived from 5-alpha reduction of testosterone in peripheral tissues, while only 20% is secreted directly from the testes. The option C regarding androstenedione is also correct. Testosterone and dihydrotestosterone both bind to androgen receptors, while androstenedione, DHA, and DHAs usually bind very little to the androgen receptors, and most of them act by conversion to testosterone. Question 3. Which of the following are true about androgens in men? As Digda told, that there is a gradual decline in testosterone levels, and because of the rise in SHBG, the decline in free testosterone is higher than that in total testosterone. The rate of decline in total testosterone is about 1 to 1.5% per year, while that in free testosterone is 1.2 to 3% per year. Aging is associated with a decreased rate of production, and in spite of decrease in rate of metabolic clearance of testosterone, there is a decrease in the total and free testosterone levels. Regarding question 5, the option D is correct. Is actually not correct. Other 3 options are correct. So option D will be the correct answer. So in response to an increased FSH levels, Sertoli cells mount response and account for a maintained levels of inhibin B. Now, as I has discussed, the cause of decline in testosterone with aging lies both at the level of the testis as well as the hypothalamic pituitary axis. In the hypothalamic pituitary axis, LH response is basal LH is usually raised. However, it is not seen in all the patients. In response to GnRH, an exaggerated LH response may be seen, which indicates that the gonadotropes usually function normally. So, and the problem most likely lies in the hypothalamus. It has been postulated that the GnRH neurons are decreased, resulting in decreased pulses, which in turn account for decreased amplitude of LH pulses associated with an increased pulse frequency. The next question, the loss of libido represents the most specific symptom. Among all these 4, the EMA study showed that decreased muscle mass and strength is not as significantly associated with low testosterone levels as the other 3 features of poor morning erections, low libido, and erectile dysfunction. Testosterone replacement therapy may be considered in men over 50 years of age if they have both just presence of clinical manifestations of androgen deficiency or just low testosterone levels are not an indication for treatment. There should be presence of both in order to indicate the treatment. Contraindications for testosterone replacement therapy include metastatic prostatic carcinoma and unexplained nodules or excessive prostatism symptoms, hematocrit more than 50% or PSA more than 4, and poorly congestive heart failure. Age per se is not one of the criteria which contraindicate testosterone replacement therapy. The least likely side effect of testosterone replacement therapy. Well, the answer here is the increased risk of prostatic carcinoma. Well, although testosterone replacement therapy is contraindicated in prostatic carcinoma, as a cause of prostatic carcinoma, testosterone's role has not yet been established. While gynecomastia, increased PSA, and reduced HDL cholesterol are well-established side effects of testosterone replacement therapy. These are the end of the answers.
Thank you, Amritabo, for going through this revision, which was much needed for probably all of us. And a question for Deep, this from Dr. Hari Kumar, who has appreciated your talk, but also wants to know, once you decide to start elderly gentlemen on testosterone treatment, how long do you continue? That will be the question that the patient invariably will ask. So how long should I take it, and how do you decide to stop, or what do you do?
It's a very
Can you now stop sharing, Amritabu? Yes, Deep.
Yes, sir. So it's a very practical and a very difficult question. So it's a highly individualized option would be the way forward. We need to discuss with the patient what are the objectives, what are the improvement patients look at. Many times we get patients brought by their son or their daughter. Ki, my dad is has gone totally silent. He just dozes off while watching TV in the morning. After breakfast, he dozes off while reading newspaper. He dozes off. He has no interest. He has stopped going for his walk. So we believe that there's something wrong with his hormones. So we discuss this. We do an objectively documented by questionnaire as well as by the hormone levels. We discuss the treatment, and the idea is to start testosterone at the lowest possible dose. So typically, what I have been doing is I start with 100 milligrams of testosterone enanthate once a month. I know that it will not be the max appropriate dose for most of them, but at least it will prevent certain surge in hormone levels. Some patients do come back with anger spells or certain bouts of aggressiveness or inappropriate behavior also. I have had patients where the daughter-in-law has come secretly alone and told, sir, could you please the hormone replacement in my father-in-law, because we have felt some inappropriate behavior in the family with the dose you are giving. So it's a very practical, highly individualized approach. I think start low, go slow would be the best way to minimize side effects until we reach a level of hormone which gives optimal satisfaction to the levels. I think a clinical satisfaction is more important than the actual some numbers of testosterone levels.
And I must also point out that as clinicians, we also are guided regarding the continuation of treatment as to the improvement of symptoms. So if the son, daughter-in-law brought an elderly gentleman because he was falling asleep while watching TV, we have to see whether the testosterone treatment actually did improvement in his symptoms. Though the testosterone level may have come up, this may not have anything to do with his symptomatology. So clinicians should also judge that and then decide whether to continue. So we should, I think, at least unless the testosterone is clearly very low, possibly if it's borderline, let's say 300 to 350 nanograms per deciliter, I would suggest that let us start on it, let us see how we respond, and there would be about 50-60% would respond very well if you bring it up to 400 or 450. And then we continue. But if at the end of 6 months of trial, let us say, and we find that the results are satisfactory, I mean the reports, biochemical reports are satisfactory, but the patient is not much improved, then we may again discuss and decide not to continue. Would you do that, Professor Mahmood?
Well, this is a good point. I mean, we should not be trapped by the guidelines. So we have to assess the patient in our rooms. So sometimes it is really amazing that you have quite relatively low level of testosterone that you achieved by the replacement, but a very good response on the other side, the clinical response. So exactly what you say. So we should not be exactly on the line of the guidelines and to follow them very strictly, because with us, I remember that we are even talking about the gray zone between 8 and 10 nanomoles per liter. I don't know how to count into the nanograms per milliliter, but
yes,
if you follow that, you are giving a huge, how can I say, range between the acceptable levels. So even with lower levels that you present in your presentation, even with 5 nanomoles per liter, maybe we can get the result. So sometimes it's really very good to ask the patient and not to follow with the higher doses and to reduce exactly what both of you said. So let's try with the lowest dose to achieve the goal.
Right, and once more, Professor Mahmood, a couple of questions for you for our understanding. For us, as Dr. Deep has correctly pointed out, we do have testosterone injections. we do have a testosterone oral preparation. We also do have a testosterone gel preparation, but we don't have a patch. So what are the preparations available in your country?
We have mostly injectable preparation. So we have the Nebido, which is the, I think the Andropause testosterone, which is lasting for 12 weeks even. But I have some patients, they just came to me last week. They are using this injection every 20 weeks, which is really amazing. So we have a long-lasting half-life of these compounds. So I mean, injectable ones are present in my country. We have some gels. We don't have any of those implants and those. So the injections are the most
rather similar. Yeah, and we in our country also have a testosterone anticanoid, which you can give every 12 weeks. After initial, maybe you have to give every 4 weeks for a couple of shots, and then you can maintain the levels by injecting every 12 weeks. I must share, Dr. Amrita Ghosh has told us that Dr. Mandeep Sharma and Dr. Piyash, he has written Piyash Gargi, the Piyash Gorgori, it will be Dr. Piyash Gorgori. They have actually scored the highest. They scored 7 out of 10. So congratulations, Mandeep and Piyash, for their excellent efforts. And we now come back maybe to a couple of again important questions. One is, I must admit, in our country, by and large, all the testosterone assays that we do are not by LCMS. It is available in some institutes. LCMS is available, but it's still not generally used for testosterone or steroid assays, by and large. All commercial assays, all assays based on which we decide treatment are mostly chemiluminescence assays, mostly. So and we also know for at the lower levels of these steroids, these other assays do not perform so well. So if we do not have an LCMS, should I not be allowed to diagnose hypogonadism? What is your view? How do you do in your country? Do you have LCMS all around?
We have LCMS, but we are not using for this purpose because it's really expensive. Yeah. So we don't have the, everyday determination. So we are using ELISA or the radioimmunoassay. With our institution, we have the radioimmunoassay, which we consider quite a good one. And I even consider a little bit more susceptible to analyze the very high and quite low levels, which the ELISA is not covering. So when we are talking about the quality, the best one should be to use the high liquid, chromatography, but this is really expensive. So we must remain on the in generally ELISA, but I also suggest that sometimes you have to check on the two methods, like the RIA, like radioimmunoassay, and maybe the ELISA, if you're not very sure. And on my opinion, it will be very good to analyze to count actually the free testosterone by dividing with the SHBG. So sometimes it's better not to deliver only the free testosterone. So it's better to use the total testosterone and to divide by SHBG, because SHBG is much under the influence of obesity, insulin sensitivity, whatever. So it's much more useful to determine it by two hormones and then to see the real situation with the patient because of these relative hypoandrogenisms or hypogonadisms in the obesity states or diabetes. So calculation is really very, very, I think that we as endocrinologists must be on a position to pressure, how can I say, our communities to deliver properly the doctors. This is very important.
Sure. And the final question, both to Deep and finally to Professor Bakut, is about the declining testosterone that we see, the slow decline in many individuals, aging male individuals. Do you think this is physiological? Does it help us in any way, or is it all pathological? Do we just allow it, let it be, or we need to run after it and fix it? First, Dr. Deep, and then Professor Makut.
A very difficult question. So I think nature has made it. If you look at the larger, nature has made it the things for the reason. I think the decline in testosterone with age, I think it has a very normal physiological role. I think with family completion and over the larger aspect, I feel a lot of human behavior, the human psychology is strongly controlled by the hormones. I think male hormone testosterone has a great way in controlling human behavior, the societal behavior at large. So I would feel the secular trends and decline in male hormones has been devised by nature. We should not be playing with it too much, but yes, if it is causing symptoms, we'll having the patients with plus minus 2 standard deviations. And then in those scenarios, I think we need to treat. But a large majority, as you suggested, does not need any treatment.
And the words of wisdom from Serbia.
Well, I totally agree. So this is something physiological, but we should not wait for the man to complain. Maybe we have to ask him earlier. This is the point, because as I said at the beginning, women and men are really different. So we have to ask them. If we notice that they are coming and being very slow and very, slow going and obese or whatever, maybe to provoke them, but in private. As you said, this is very delicate question. So we must point, especially with males. Women are much more open. These are the estrogens. So we must ask them in private and to ask directly without questionnaires, what's going on? I mean, do they have any problems? So this is physiology, but we can sometimes, to fix it or to support them.
Right. Yeah. Thank you. Thank you very much. I think we had a wonderful talk, great comments from Professor Makut. And I think we also ought to give a prize to our quiz master, Dr. Amrita Ghosh, because it's not that he has made it impossibly difficult that no one could answer anything, but at the same time has made sure that the highest mark scored is only 7 out of 10, not 10 out of 10. So I think that was a balanced quiz that was presented. So thank you very much, Amrita. Thank you, Dr. Deep Dattu. And of course, thank you, Professor Juro Makut. Till we meet again, stay well, stay healthy.
Thank you very much for being with you again.
Yeah, thank you. Would Sheila like to say something finally on behalf of the society?
So that was great learning. A big thank you on behalf of the Endocrine Society, both to you and Professor Makut for spending a Sunday evening with us. And of course, hats off to Deep, as usual, exemplary. Amritava, I also think I would not have scored more than 7. So I think I did a lot of learning. I'm sure a lot of people out there also learned a lot. Thank you very, very much. It was a pleasure. Till we meet again.
See you.
Thank you.
Bye.
Bye.